So this is how I give the anterior incision. Only the skin is incised here, and then blunt dissection is done with the index finger, and you will easily reach the fracture. So this was my first patient in which I did the DHS maneuver. Here you can see the AP view and the lateral view of the X-ray. You can see the combination and the displacement. This is the traction view on the traction table. Here it doesn't look that much displaced, but here you can see on the lateral view there is so much displacement. So I tried the traditional way. I used a Homan and tried to lever it down, but as here you can see the fracture, I was able to bring it only this much down. The problem here is that the fulcrum is soft tissue here, so the force cannot be transmitted effectively to bring that fragment down. So here I thought that what if we bring an instrument from the other side which hinges here, and then there will be a bony fulcrum and we'll be able to easily bring that or keep that down. So here is what I did. Mark the incision site. The incision site is exactly over the fracture site or just lateral to it. Some surgeons were asking what about the neurovascular bundle. The neurovascular bundle is right here, just above the head here, and we are far lateral from the neurovascular bundle here. So here you can see I have entered the my artery into the fracture site, but I have not yet reduced the fracture. Here in the lateral view I have pushed the thigh up, and then with the artery I have pushed the proximal fragment, neck fragment down, and here you can see that the reduction is perfect here. So now we will see what are the technicalities here. Here you can see on the lateral views the displacement is so much, and you can think of it as a seesaw where the apex is at that fracture tip, and the vector on and the torque on one side, that is F into R, is equal to the torque on the other side. As you can see here that the small r is very large, so the force required to pull this fragment up will be too much, which will lead to bending of the artery and you will not be able to reduce the fracture. So what you can do is push the thigh up. Pushing the thigh up will reduce the small r, so the force required, which is the large F, will be very less. So you will be able to easily hold the reduction and the artery will not bend. Now after reducing the fracture, two K-wires are passed in the lateral view. As you can see, they should go anteriorly, so they should not impede the way of the nail or the reamer. Now here is the AP view where you can see that the two wires are holding the fracture along with our artery, and all is used to make the entry point here. As you can see, I always do medial entry as middle as I can. Here the all is passed inside, and as you can see that the artery is still inside. This is the lateral view. Here you can see that I'm not holding the artery here, I'm not pressing it down. This is also the reason that the fracture has displaced, and you can see here that the K wires are not able to maintain the reduction. This happens because your assistant has to move away. Your assistant has to remove his hands from the artery because we have to see the lateral view, and the assistant will come in the way of the view. So here the artery is left as it is in the fracture site. After that, the guide wire is passed and reaming is done over the guide wire, and after reaming the nail is passed. Here you can see that the artery is still inside the fracture site. It's holding the reduction, and still the nail is able to pass. After passing the nail, reaming is done, K-wire is passed, reaming is done, and then screw is put. So here you can see that the reduction is perfect here. So if you get that much perfect reduction in your first attempt, why wouldn't you use the maneuver again and again? So the post-op x-rays, you will see this is the post-op AP view and this is the lateral view. You can hardly see the fracture line running here. So the next case, in the first case we have kept the artery in the lower aspect of the fracture site. Here we will see what it does if we keep it in the middle. Here again entry is made over the fracture site, then an artery is passed inside the fracture and fracture is reduced. Here you can see the lateral view, fracture nicely reduced. And after that, K-wires again in the lateral view, K-wires, 2 K-wires are passed to provisionally hold the fracture, and then an awl is used to make the entry point. Here you can see that the artery is impeding the way of the awl. So the awl is going medially, the awl is not going laterally. So this can be a blessing in disguise because your awl should go medially. But if you don't want your awl to go medially, you can remove the artery here. Then after that, a guide wire is passed. Over guide wire, reaming is done. And after reaming, the nail is passed. Here the artery was blocking the way of the nail. So what I did was I removed the artery and brought it anterior to the nail. Here you can see that it is anterior on the nail, hinging between the nail and the anterior cortex. So I was really able to feel the nail here. You will be surprised to know that the fracture site is really subcutaneous here. You just give the incision, 2 or 3 centimeter incision, you pass your index finger inside that incision and you will be able to feel the fracture site, because when there is so much displacement of the fracture, the interior fascia is ruptured and you can easily feel that fracture fragment there, and you can even feel the nail. I was able to feel the nail so many times here. This is in the AP view, the artery is, as you can see, it is anterior to the nail, and here I have passed the screw. Here you can see that the lateral view, perfect reduction lateral view, and in the AP view again perfect reduction in the AP view. So you will say that these are simple cases. What with this spiral subtrochanteric fracture? So let's see that one too. Here you can see that the fracture site is running so much distally, so you can't even see the full fracture down here. And this is the lateral view, again so much anterior displacement. So what I did was again DHS maneuver, fracture is reduced, I passed 2 K-wires anteriorly, and then again in the lateral view entry is taken. As you can see that my entry is always at the junction of anterior 2/3 and posterior 1/3. After making the entry, a guide wire is passed, reduction is still maintained. Here you can see that the K-wire is nicely hugging the calcar here. There is slight opening on the medial aspect here. So what I did was I brought a Homan from the same incision from where I will put the screw, and you can see that the opening is reduced. After reaming, I put the screw here. Here you can see that the screw was hugging the calcar and it had just opened the fracture here. But immediate postoperatively, the fracture collapsed, and here you can see the reduction. The reduction is perfect here. Here you can see that the spiral fracture is so much down here till this level, and on the medial side till this level. But the reduction is perfect here. Here you can see that this is not exactly a lateral but oblique lateral view. Now you will say that these are simple fractures with lateral wall is not broken in these fractures. So let's see one with the lateral wall broken. Here you can see that the GT, you can't see proper GT here, and the neck is still here. So here you should aim for an entry medially. It is most important in cases where the GT is not there. In the lateral view here you can see that the GT is flying away, the shaft is flying somewhere, the neck is going somewhere. So what I did here was again pass the entry inside the fracture, then turned it 180 degree, pushed the thigh up, and then made the entry with the awl. Here I tried without the K-wires. I thought the fracture is not displaced, so let's try it with the awl, not using the K-wires, only using the artery. So here you can see that the displacement has happened, inferior displacement of the neck has happened. This has happened because the K-wires are not there which were holding the fracture. This is the most important indication of the K-wires to prevent the displacement of fracture during entry. Here you can see I am going medially here, which is most important in intertrochanteric fractures. This is the lateral view. You can see that the fracture is reduced here, and after making the entry with the awl, a guide wire is passed. Over the guide wire, a reaming is done. As you can see here, my reamer is going medially. So in intertrochanteric fracture, this is important. Your reamer should go medially. After reaming of the fracture, nail is passed. Here the artery is still inside, but the artery was not letting the nail go inside the fracture. So I removed the artery here, proceeded with the screw insertion. Here after removing the artery, the fracture was not displacing because here I have made the entry medially and the nail has gone through the neck, so that there is buttress of bone both anteriorly and posterior to the nail, which prevented the displacement of the fracture. Here the guide wire is passed. As you can see that it is hugging the calcar area. Then reaming is done over the guide wire and then screw is put. So here you can see that the artery is coming in between the path of the nail. So what to do to prevent this? This was the case where I modified the technique a bit. Here you can see I just retracted the artery backwards a little, so that it's just hugging the anterior cortex of the distal fragment, so that it doesn't come in the way of the nail or awl or anything you put inside the medullary canal. And this is the postoperative X-ray. Here you can see posteriorly there is so much comminution, you can't see any bone, but anteriorly you can see the nice reduction here. Now I will show you one case where there is no reduction needed initially, but during the surgery the fracture displaces and the need for DHS maneuver comes into play. Here you can see in the lateral view the fracture is nicely reduced, so I just put one K-wire. I thought there's no need for second K-wire, so I put just one K-wire in the fracture and then proceeded with the surgery. I used the awl to make the entry. Awl is being passed inside the bone. After passing the awl, a guide wire is passed and reaming is done. Here you can see reamer being passed. The reduction is displacing a bit here. So what I did was I used the artery and put inside the fracture site to reduce the fracture, and here the fracture is reduced. Then the nail was passed and wires for the proximal and distal screw were passed here. This is the AP view. The artery here is anterior to the nail. As you can see here, it is anterior to the nail. Here also you can see that it is anterior to the nail. It is not blocking the path of the nail. Then the first upper screw is put, and then the lower screw is put, and then the lower screw will be put again. Here you can see that the reduction is perfect here, and the upper screw you can see that it has backed out a bit because there was almost no purchase intraoperatively. So I put the patient on bed rest for 1 month. Only bed sitting and knee bending is allowed, no weight bearing. So to summarize DHS maneuver, first of all, where should be the entry incision? The entry incision should be directly above the fracture site or just lateral to it. Second is what type of instrument can be used. I have only used an artery forceps so far, but you can even use a Homan, but I doubt the Homan will block the way more. And then is what about blocking of the canal by the artery? So to prevent this, you can just retract the artery forceps a bit so that it just abuts the anterior cortex as I have shown earlier. And another way is to remove the artery from inside the fracture site after putting the two K wires or after putting the guide wires. And next question is, what about bringing the artery again? So before putting the neck screw, you have to insert the artery again so that the reduction is perfect. Next is, what type of fractures can be reduced by this maneuver? The intertrochanteric flexion type fractures can be reduced by this maneuver. So the video is already long, so I will discuss the algorithm for intertrochanteric fracture fixation in the next video. So stay tuned and make this video viral so that a lot of orthopedic surgeons can benefit from this maneuver. Thank you.